Okay, let's get started if we can, please. Sorry, we're a couple of minutes late, but welcome to the March board meeting for the CQC. We don't have any apologies for absence, but we do have a couple of colleagues joining us on the screen, and they are very welcome. Also want to welcome Becky Appleby-Dean from our LGBT plus network. You are extremely welcome, and do feel free to raise your hand, shout at me or whatever if you want to come in. I want to just advise both the board and anybody who is watching this that we are going to be supporting the National Day of Reflection as we've done previously. So that means we will have a 1-minute silence at midday, and if obviously anybody's watching this other than in real time, it will look a bit odd, but that's what we will be doing at midday, just to explain. I don't think there are any other sort of introductory comments that I need to make, in which case, can I just ask the board if there are any declarations of interest anybody needs to make? That's okay. That takes us to the minutes of the 23rd February meeting. Are they true and accurate record of all we discussed? Very good. Those are approved. There's one item on the action log, but that is, that is due today. I was going to say it's not due until next month, but it is due today. So we'll come on to that later, Chris, I imagine. And then I think unless there's anything else arising, we can go straight into the executive team report. Ian.
Thanks very much, Peter, and good morning, everybody. I want to say a few things I just wanted to bring to the board's attention. The first thing is a couple of confirmation of 2 appointments. As you know, we've been talking about a new chair and a new chief inspector of hospitals over the last couple of meetings, and I'm pleased to formally confirm now that Ian Dilks is our new chair. Ian will be joining us from the 1st of April when Peter's term expires. I can also confirm formally that Dr. Sean O'Kelly will be our new Chief Inspector of Hospitals. Sean, we hope, will be with us towards the end of June. We hope his first board meeting will be the June board meeting. And in the meantime, I will, of course, work with Dr. Rosie Bennyworth as our senior medic on the board, as well as the Deputy Chief Inspector colleagues to cover the Chief Inspector position in the interim position. But we look forward to welcoming Sean, as I say, at the end of June. I just want to again just update the board on the publication of our equality objectives. We published those, as you recall, back in July 2021. The paper says 22; it should read 2021. And we've done a 6-month update. I think we've made good progress across all of our equality objectives, and they are, of course, on our website in more details. Just a couple of comments on recent engagement. I have met Sir Gordon Messenger and Dame Linda Pollard, who are carrying out a review of leadership within health and social care. And I know a number of other senior colleagues have had a number of very detailed conversations with Sir Gordon, Linda, and of course the other members of their team. I think what we're trying to do is move to a position where we can blend the recommendations that the Messenger Review will be making into our methodology to make sure that those things are complementary. As we've talked about in the past with the board, we are in the process of creating a single assessment framework, and we'll be launching that later on in this calendar year. And if we possibly can, we'd like to blend the Messenger Review recommendations into that framework as it evolves. I also just want to flag that we've Rosie Bennyworth and I have had a number of visits with ICS system leaders. I think they've been very productive conversations. I think we've talked a lot, and I think a lot of partners have talked a lot about the importance of integrated care systems and the opportunity that they add real value to individual places right across health and social care. And I think we've had some positive conversations, but I think the point really here is just to re-emphasise the point that as we develop our new methodology, we want to do that as far as we can in partnership with those people who are going to be regulated. I'd hope that by the time we get to going live with this methodology in this time next year, we'll be in a position where those being regulated will have had a good opportunity to contribute. We'll have got a really good sense of some of the real challenges that are out there, and our regulation will be both proportionate and effective, and make a real difference to support the standing up of these new and important constructs within the health and social care landscape. So, Peter, that's all I had for now, and I'm happy to hand over to Kate, unless we've got colleagues with questions. Thank you.
No? Okay, Kate. Thank you.
Lovely. Good morning, all. I'm going to start by talking about visiting, a regular conversation we've had at board, and a significant area of focus for our inspectors when they go out and inspect care homes in particular. So since we wrote this paper, the government has updated their guidance on visiting. The most up-to-date publication was released yesterday, and in that it reminds the sector that there are no government directives about visiting, bar it should be happening. And it should be happening in a safe way. So it talks about good infection prevention control, etc. The guidance continues to talk about instances where visiting may look different, which is where care homes are in outbreaks. So that's circumstances where 2 or more people have COVID. And in those circumstances, the government guidance continues to be really clear that even in an outbreak, when people are receiving end-of-life care, they should have access to see their loved ones. And even in outbreak, all residents should have access to their essential caregivers. So as we've talked about at this board, it is a key area of focus on all of our inspections. And what I would say is inspections we've done looking at this area since December in particular. So we've done 2024 care home inspections where we've looked at infection prevention control and visiting. In 97% of cases we were assured on visiting, and in 3% we needed to do a little bit more work to get that assurance. And we continue to respond to concerns raised with us by people who receive care, their families, where visiting is not happening along with government guidance, and in every instance we are taking action. So just to give a number to bring that to life for board, we've had 226 concerns about visiting since the 1st of December, of which 98 were concerns about blanket bans. Every one of those 226 have been looked at. 61 inspections have happened or are in train, and in 19 instances we have taken a degree of regulatory action, and in one of those 19 instances the provider's approach to visiting has formed part of our notice of proposal to close the service. So this is an issue we take very seriously, because we recognise the impact it has on residents' well-being and their family well-being. So just wanted to update board on our actions around visiting. Is that okay? Sorry, do you want me to pause and take a question there, Peter? Do you want me to?
Robert.
Thank you. I'm glad to see that the government, as it were, has lifted things which essentially should mean that visiting goes back to the practices that were in existence before, but no doubt with some extra precautions because of COVID. And it's about that I wanted to ask. The infection control measures obviously are expected to include protection around COVID, which in many places, as I would understand it, involves sometimes wearing gloves, aprons, masks and so on, all of which are the antithesis of the normal visiting many vulnerable elderly people would want or benefit from. And I just wonder whether you're aware of what, if any, is the evidence base behind the effectiveness of some of these, which have now become quite habitual precautions, and whether anyone is reviewing those, because it does seem to me that if they're not actually necessary, well, there should be a greater degree of flexibility about them.
So I would say that we're not the best experts in this. So we point providers in the direction of government guidance and advice that they may get from their local health protection teams, local directors of public health, etc. And it's obviously bespoke to each individual home, each different service. But the things that you would expect providers to do are things such as good infection prevention control. Some providers are still asking families to book ahead of time so that they can manage the numbers of people coming in and out of the services. So I would suggest that the government who produces the guidance based on scientific evidence is where are best placed to answer that question. And our job is to hold providers to account for making sure that they are following the most up-to-date guidance based on scientific evidence.
Okay. Thanks, Kate. I mean, we know this is a really important subject, and thanks to you and your team for all you've been doing to make sure that people are able to access their loved ones as much as possible. So thank you.
Okay, two other bits for me. So since we last met as a board, the end has come to vaccination as a condition of deployment for people who work in care homes. You'll remember this was a new power, a new requirement for us to judge against that came into force in November. The decision was made to reverse that in light of the most up-to-date scientific evidence, and we are no longer holding care home providers to account for this element. We are taking a case-by-case approach to cases where we had identified an issue prior to this condition no longer being in place, and we will make individual decisions about what we do about those cases. But from the 15th of March going forward, we are no longer holding providers to account for this requirement. And then the final thing for me is an ongoing focus we've been bringing to board on workforce. And our focus is kind of twofold. One is what impact are the workforce challenges having on the quality of care and the continuity of care being received by people. And then the second is what impact are workforce challenges having on the stability of the social care market. So these are figures that you're familiar with, but this is just bringing you up to date with the most recent data, which is we continue to see a very high vacancy rate in care homes. However, that does appear to have stabilised over the last 2 months. So I don't think this is a cause for us to no longer be concerned, but it is positive that it is at least plateauing at still a very notably high rate, and turnover rates continue to be high for colleagues working in this sector. You may recall we introduced exit interviews for social care providers leaving the market. So quite early days into doing this, but what is coming out as one of the main drivers for social care providers exiting the market is the recruitment and retention of workforce. So for those reasons, we will continue to focus on workforce and the impact it has on quality and stability as a sector.
Kate, I was with a care home provider the other day, and I was asking about their turnover and whether people were leaving the sector altogether or just moving between providers, and the answer was just obviously just one provider. It was about half and half. Is that what you might think is a reasonable sort of national situation?
So I'd say it's varied over time. So I think during the pandemic, I'm thinking of last summer in particular, there appeared to be quite a flow out of the care sector full stop and into tourism, where we saw that real boom happening. Often you just see a kind of churn of colleagues moving from provider to provider. So I'm thinking about the adult social care white paper that was published before Christmas, and the government's ambitions about workforce and moving to a place where people, care workers, have much more passport qualifications. That means that they're not starting from scratch when they move between providers, and there is a kind of nationally recognised standard when it comes to training and qualification that enables, as I say, quite a fluid workforce to move, but to move with their recognised kind of accreditations as well, rather than each time kind of starting back at scratch. But it tends to flow, Peter, as to the percentage that leave versus the percentage that just rotate between providers.
I mean, it just seems to me it's something that we should be watching quite carefully, because there is a huge difference, as you've just said, between having to recruit people who come already with experience of working in the sector and recruiting people who previously were doing some completely different job and need much more training. And so when you come to the sort of quality of care that people are receiving, I think there's quite a big difference between the two. So I'd just be really interesting to sort of try and watch what the trends are. Thank you. Mark.
Thank you, Chairman. And Kate, thanks for the people data from adult social care. I mean, these stats are really important to show the pressure that the system is under. Equally important are the steps that the sector are taking to reduce turnover through learning, training, development, trying to reduce the pay squeeze at that level of the market, and how to attract people into the sector. Last meeting we were signposted to the Skills for Care report, and part of our strategy is to drive improvements. So should we and could we not promote innovation and success stories in this area to encourage transfer of best practice? I wonder whether it's fair to ask you that question, or whether I should have addressed it to Chris. But it seems to me that's an opportunity for us to help the sector.
Thank you, Mark. If I start and then see if Chris wants to come in. So if you cast your minds back, I think 2 boards ago and 3 boards ago, we had an annex to the Chief Exec's report which brought to life the workforce detail in social care. It was a bit more fuller, and it talked about things like events that stop a service. But also in that annex, we drew out some examples we had where providers had been successful around recruitment and retention. And it had things such as, refer a friend and get a bonus. It had things such as, financial bonuses for retention, and we know that staff having access to training and being able to see a career progression, a career pathway, is kind of really key as well to retaining staff. So we have done it before. I anticipate it will feature in our State of Care report, but that's still a little while off now. But I absolutely take on board the challenge that says, as well as continuing to call out our concerns around recruitment and retention, it would be great to match that with where providers are still, despite all these challenges, managing to be successful in recruitment and retention. And we've done it somewhat, but we can certainly continue to think about how we do that. Chris, do you want to come in?
Yeah, just to build on that, Kate's absolutely right. We've done some work to look at how organisations are being innovative in their HR practices. There's a wider piece of work as well, which we began last year, which is about enabling innovation in health and care, which has a number of strands to it, one of which is a relationship between the use of technology and people, and how both can complement each other in how services adapt and change. And I think a combination of highlighting innovation in the use of technology and people together, and also the innovation we've seen in terms of the people practices in organisations, I think can be supportive of innovation and change in system areas.
Okay, could I ask, is there any new news on the government's follow-up to their white paper that you mentioned from December? Because if I'm remembering rightly, something like £500 million promised for investment in the workforce. So as long as all of the things, alongside all the things we can do in terms of sort of disseminating good things that providers themselves are doing, that investment in building the supply of the workforce is fairly critical. Is there kind of any new news on when that flows?
There is ongoing work about taking the vision I think we were all enthused by in the white paper and translating that into a kind of plan with milestones that the sector can know what to expect by when, and we are really keen to see that as well. So, so we've talked about welcoming the additional money and being very keen to see that rapidly flowing through to frontline. We've really welcomed the focus on a care certificate that is passportable, as I mentioned earlier. And you may recall there was a small reference in the white paper to exploration around what might it look like if the workforce was registered. And again, really welcome that, but said we'd want to see that explored with people who use services, the workforce, etc. So there's lots of work underway, Stephen, that we are plugged into, and we are really keen that that can be shared so that people who work in the sector and people who receive care can know when they can start seeing the benefits of, as I say, a vision that I think we could all get behind.
Great, Kate. Thank you very much indeed. Ted, you've been waiting patiently. Over to you.
Well, thank you, Peter. And this is my final report to the board. I have to say, I'm really disappointed not to be there in person to deliver it in person. So my apologies for that to colleagues. In this report, I'm going to highlight 3 areas that are actually pretty recurrent themes from our reports over the last 5 years. We're making progress, I think, in all these areas, but there's a long way to go. First of all, I want to highlight the recurrent issues around the delays in the urgent emergency care pathways across the whole country. They're continuing to cause serious concern for me and for the clinicians who are providing those services. And we hear regular reports that delays are affecting the safety of patients, but also their ability to access timely and effective care when they need it. We've continued our programme of integrated inspections of urgent emergency care pathways, which we've described to the board before. We've published a report on the North East London system at the beginning of this month, and last week we published a report on the urgent emergency care system in Gloucestershire. We'll be publishing further reports in due course over the next few months. While these inspections have shown much good practice, and it's important to emphasise we do see good practice in all systems, both systems we've reported on so far are still not fully integrating services, and patients are still not able to access the care they need without attending accident emergency services. Both systems saw delays in discharging patients who are fit to leave hospital, causing acute pressures at the front door of hospitals and in ambulance services. And it's those delays at the front door and in ambulance services that are causing us most concern. My colleagues will be holding a national workshop in May to highlight these issues that have been emerging from our inspections, but also to work with services in identifying the action they can take to keep people safe while they're working under these pressures. As we've said before, we need immediate action to keep people safe, but equally we need systems to look at the models of care around urgent emergency care to produce pathways that can maintain the flow of patients more effectively, but also make sure patients are getting care they need at the right time in the right place, rather than having to resort to going to the accident emergency department where that's unnecessary and creates enormous pressure on hospitals. I'd just like to move on to maternity services. We're holding a national workshop on maternity services for representatives from NHS maternity services to discuss the challenges they face. These are the challenges we've identified in our inspections, of course, but also I expect these to be made very clear in the report of the Ockenden inquiry, which will be coming out in next week's time. There's a real consensus around the need for change in maternity services to drive forward safety. And I think that consensus is really important. We've been working hard with other national bodies and stakeholders and with public groups to make sure that we have a real focus on safety going forward. The roundtable that we're planning later in the year will be an opportunity to take forward some of the actions that are necessary to deliver on that commitment. And I'm really looking forward to seeing what comes out of that in terms of our ability to drive change. It does need concerted action by the services themselves, but also by all the national bodies, including the CQC, but other regulators and other national bodies as well, to make sure we drive consistent improvements in maternity services going forward. And finally, I'd like to highlight the work that we have underway at the moment in our acute hospital inspections to review the care of people with learning disabilities and autism in acute hospitals. We expect to report on that work later on in the summer. It is currently incorporated into our acute hospital inspection programme. Thank you, Peter. That's all I want to say at the moment.
Thank you, Ted. Anybody want to add anything or ask anything? No, it's a great report, though. Thanks, Ted. Rosie, over to you.
Thank you very much. And I just want to update the board on 2 areas, one that's not in the report, just to follow on from what Ian said about ICS work and regulation. Just to let the board know, we've started our series of co-production events and we're very keen to co-produce our methodology with a very broad range of stakeholders. So on Monday we held the first co-production event. We had over 100 stakeholders attend from a whole range of different organisations, from ICSs, local authorities, CCGs, voluntary and community sector organisations, and experts by experience, as well as the Department of Health and Social Care and NHS England. And we've got lots of rich data from that. We're continuing with further co-production events, both around the local authority assurance and the ICS work, and we will bring back some information regarding the themes from that work as we go along. The second area I just want to talk about is the ongoing work we're doing around clinical searches in GP practice inspections. As we've talked about at the board before, over the last couple of years, we've been really developing our approach to try and get much better picture as a regulator of the outcomes for people who are using services, and particularly in general practice around the clinical outcomes. And general practice uses clinical systems that enables us to get a really rich picture of the quality of care by interrogating those systems. And we have, for the last couple of years, been working on approaches where we've been running a set of searches within a clinical system to really look at things like, are people on high-risk drugs being monitored effectively? Are people who are having blood tests diagnosing diabetes, are they being appropriately diagnosed with diabetes? Are people getting the correct treatment for their needs? So we can get a lot of rich information from these searches. What we've been wanting to do is make those searches open and transparent for practices, because we think that that will drive the improvement long before we ever go near a practice. We think if practices can see the types of things we're looking at, it will drive that improvement to happen without us there. And I'm really pleased that we've going to be starting a pilot to look at actually how, firstly, there's some validation of our searches just to check. We've looked at all of the areas we need to think about, which we think we have, but we want to just validate that. But secondly, the company that we're going to be working with will put those searches and enable those to be visible for all people to import into their clinical systems, so that actually practices can look at those areas and find out how they're doing in those areas, so driving that improvement. So that's my update. Thank you, Peter.
I think that's really, really exciting development, and I mean our objective is to see good care, and anything that encourages that, with or without our intervention, is good. So thank you, Rosie. Excellent. Tyson.
Thank you, Peter. I think my written update covers most of what I wanted to say. Performance in February has been stronger than January, particularly in adult social care and in the National Direct Monitoring Approach team. As expected, it's taken some time to rebook the inspections in primary medical services and hospitals that were stood down over the Christmas and the New Year period, but that is starting to pick up and will continue as we maintain our more normal operational tempo. I'm expecting overall there to be fewer inspections in March. That's mainly because in adult social care we have moved away from the quicker infection protection control inspections to much more complex risk inspections, which is very much what our plans were going ahead, and I'll update the board at our next meeting.
Tyson, I mean, COVID is on the increase as we speak. So presumably that's going to affect some of our inspection numbers, just because our own staff are going to be off or isolating.
Absolutely, and we will keep a careful watch on that, and we will keep a careful eye out for the latest scientific advice if we need to change our posture at all. But we have regular management information about who is in work, who is not in work, and we will be able to adapt our priorities accordingly.
Yeah, so I wasn't looking for change of guidance. I was just recognising that people are rightly not at work because they're ill, and in large numbers, probably, or larger numbers.
Yes.
So that's going to have an impact next
month.
Yes,
no, absolutely.
Yeah. Okay. Thank you. All right, we're happy to move on. Chris.
No, mate, thanks, Peter. So this is our January performance update for the year, just a few areas to pull out for the board. So in the business plan over the course of the year, we've been tracking the regulated activities we undertake through our inspection and direct monitoring activity, which, as indicated in the paper, is 21.4% for the year to date. Alongside the inspection and DMA activities, we also publish public statements, as we've mentioned previously. We also receive information of concern through safeguard and whistleblowing and complaints, which means that the true picture of regulatory contact across the year is far higher. When you factor these in, moving away from, as it's prescribed in our business plan, shows we've actually had regulatory contact with 75% of services across the year. We will be reporting on a new business plan in the coming financial year, which hopefully will revise this wording. On registration, we have been trying to bring down the timescales for a simple, normal and complex average days of completion. We're seeing that normal applications are reduced by 4.2% for the year, complex 1.3%, but we've actually seen an increase in simple 6.2%. I think the performance across the year has been variable, which in part comes from the demand-led service that we're working with. In February, however, we can see a surge in improving performance, which we'll obviously update on next time round, but we can see that is really markedly improving, and the team have also processed just over 30,000 registration applications in this financial year. Mentioned previously about give feedback on care and the increase in volumes on that. We've had 50% higher responses than the same period last year, and as previously mentioned, primary medical services sector is where we seem to be getting most of our responses. Obviously this updates to the end of January, but we've seen in February the volumes at the highest rate for 2 years. So we're just reviewing this findings, and we'll bring that back to board as we start to close out the year with the findings of the year. We'll also be able to provide, we've got our annual provider survey and stakeholder surveys are now closed and being analysed. So this is key for building in some quality feedback in addition to the performance data and metrics that we track, so we'll bring that back. And finally for me, just in terms of our financial position, underspent by 13 million year to date. This is forecast to reduce to 11.7 by the year end, and on our capital budget 2.6 million underspent, and that's forecast reduced to 0.4 million by the end of the year.
Chris, while you have the floor, can I go back to the action log? I was misreading it earlier. So I think you have now adjusted the metrics, so we can close the item.
You can close the item. You'll see that as part of the next quarterly update where we provide the dashboard, but the narrative is slightly incorrect in there, and the associated risk rating, so that has been acted on, and you'll see that as part of the next quarterly update.
So do we want to keep the action open until the next quarterly update, or close it down? I just need to...
You can close it down.
Close it down?
Yeah.
Everybody agree? Yep. Good. Oh, Robert doesn't.
I had a question, that was all, something else. I agree fervently with you all the time. My question was about the response to risk inspections, where the good news is that 57%, well, good or bad news, was that 57% were required improvement or inadequate, which is good in the sense that it justifies the risk to which we were responding was a real risk, and therefore that is good in that sense. I assume that the rest would have been rated as good, at least, and I just wonder what reflection we have or ought to have on, is it whether specificity, or I don't know if it's that, or the sensitivity of our response rate. In other words, are we looking at the right things for risk? And do we have a measure of how we do that?
Shall I make a start, and then Rosie or Tyson might want to come in as well? So, as you say, Robert, I am heartened that our data and our intelligence and what we know about services, including the invaluable information we get from the public, are pointing us to go out and cross the threshold and visit services where we need to. And in adult social care, it's 52% of our risk-based inspections are informed by information we get from give feedback on care. So we're going out to these services, we're finding areas of concern, and we are either down, reducing a rating, or we're finding breaches in regulation and taking action. So it is signposting us to the right places. Some of the inspection activity that isn't triggered by risk might be a previous rating that requires improvement with a breach or an inadequate rating, where we might go out and actually find some improvement. So we might see that service go up as well. And as you know, we've committed to date to ensure that a smaller number of our inspections are still going out and finding that improvement. So we might go out to a good and find a good, or we might go out to a good and occasionally find an outstanding at the moment. We are looking to shift our focus, and Tyson will talk about our priorities going forward, where we want to continue to do risk. That will always be our number one priority, but to see an increasing number of kind of improvement inspections as well. But I think the data is showing us what we would want to see, which is our intelligence, our information from the public are sending us to services where we should be going, because we are finding poor practice and taking action. But we are also going out and inspecting services where the quality of care wasn't where we'd expect it to be, and in circumstances we are finding improvement, and that's being reflected in some ratings that are going upwards as well.
Tyson, yeah.
Thank you, Peter. Kate's absolutely right. The only thing I would add is that I also think that, as well as inspecting risk, and the figures here show that we are finding some risk. I think from the wellbeing point of view of our teams, also continuing to inspect good, or where we're looking for improvement, it is good. I think if our teams are constantly looking at areas that aren't performing well, I think that will have an impact upon them. So I'm keen for us to keep a balanced portfolio going forward.
So I mean, I think there are other reasons for doing that as well. I mean, so I think this is really, really good news. I mean, it's been an ambition of ours for a very long time to get ourselves into this position, so it's great. But it's also important that we go back to services periodically where there isn't any reason to be concerned. So I think there are two reasons for going back to good and indeed outstanding practices. Okay. Right, so where does that take us? Mark, I think to you.
Thank you, Peter. So there are no significant cyber or information security issues to report this month. As per previous updates, we continue to monitor guidance from the National Cybersecurity Centre and take any action as necessary. Worth saying that we are continually reviewing our cybersecurity position and taking continuous improvement action, such as recently we've launched our cybersecurity education and awareness program for this year, which is well underway. Thank you.
Good. Okay. And then lastly in this section, t'other Chris.
Just three things to highlight from this month's report. On the 9th of March, Ian, the Chief Inspectors, and myself led an event in Parliament to discuss our transformation work, with a particular focus on our approach to assessing both providers and local systems. Parliamentarians were interested in how we would still capture the voice of people using services in our approach, and also the part that data information would play in that insight moving forward. We were able to be clear that we will continue to focus on the voice of people using services through data insight that we gather through direct contact and crossing the threshold, through give feedback on care, and through our use of experts by experience. And I think this really does give us a much richer picture of people's experience in more real time, just as Kate was talking about the use of give feedback on care to drive responsive inspections. In terms of the bill, the third reading of the Health and Care Bill in the House of Lords is taking place today. We don't expect any significant discussions on CQC. The purpose of this stage of the bill is to sort of effectively to tidy up the bill and to make sure that it's effective and workable. So we're not expecting any further amendments. The one sort of exception to this, I guess, is the Baroness Hollins amendment in which the government has accepted. The amendment creates a duty on the Secretary of State to issue a code of practice on learning disabilities and autism training. and amends our existing regulation in line with that. And we're working with DHSC on how that will be implemented. Finally, just two things that we've this Friday we'll see the launch of the outer site follow-up report, which will track the progress on the outer site review that we did for the Secretary of State back in December 2020. The report will give full details of the progress that's been made and further action that needs to be taken. And then very finally, today we'll be at the JCHR later, which I think Kate will be acting as the main witness. That's it.
Good. Thank you, Chris. Are we happy to move on? Right. Mr. Usher, back to you, I think. Oh. Right, okay, Kirsty. I get this wrong every time. Normally I say Kirsty and you say, no, it's Chris. No, you don't, the other way around.
Don't worry.
Okay.
Thank you. So just an update on our business plan refresh. As we've said previously, we will update our business plan every 6 months to reflect the fact that we are in a state of flux through transformation, and we want to make sure that the measures that we are using to monitor our performance keep constant with the pace of change that's going on in CQC at the moment. So this refresh plan sets out what we're going to do between now and September. It focuses on our ability to deliver against our regulatory obligations, ensures strong alignment to our strategic ambitions, and ensures that our transformation activities are prioritised and aligned to delivering our interim operating state 2, which is our second phase of our transformation. We have rolled over the majority of our objectives from the previous plan, as we felt those were still current, and we have updated the transformation section to reflect the new priorities to deliver on the next phase of transformation. Our revenue budget for the year, it has been set at 237.4 million, which also includes a reduction in 5% in our GIA allocation, which is in line with our spending review settlement. So the plan is there, and I'm happy to take any questions if anyone has any.
Questions? Gosh, getting away with this lightly today. Mark, sorry, beg your pardon. Thank you.
Thanks, Chairman. Not so much a question, but just a comment that I'm really pleased to see under the Managing Our People and Resources, the section about improving the differential experience of our colleagues as reported in Pulse Service. Really pleased to see that. And of course, it links really well to our people plan, and it links particularly to presentations we're going to get later. So thanks very much for that.
Thanks, Mark. Sally?
Thank you, Peter. I just wanted to endorse what Mark said about improvements to the business plan this time round. As you'll know, there's been quite a comprehensive review through the Audit and Governance Committee, and a strengthening of some of the measures, which I think is really important. They're quantitative and qualitative measures, and we'll come back to deliver those. I suppose I just wanted to reiterate what Kirsty said about our budget, and the fact that there is, as part of our need for all organisations to generate savings, a plan to be able to do that, but also a slight risk as we rejig, particularly as we look forward to think about our pilot work on integrated care systems. But this is a good business plan, which we should note and endorse and come back in 6 months. Thank you.
Thanks, Sally. Anybody else? So, Board, are we happy to agree the refreshed business plan? Perfect. Well done. Thank you, Kirsty. Thank you, Chris. So we then move on to the Workforce Disability Equality Standard and the Workforce Race Equality Standard update. Jill is not joining us, but Rachel Mackay is. I hope.
She is. So we're a few minutes ahead of time. So.
Yeah, it just doesn't often happen. Exactly. So we'll just wait for a second. Chris, while we're waiting, on the bill, it's third reading in the Lords today. And do you happen to know when Royal Assent is planned?
So they've indicated it will be towards the end of next month. So we've got a sort of a rough gap. I don't know if, certainly from my perspective, there was still a little bit of gardening to do to make sure that the bill was workable in final form before that. So I think we're looking at, but obviously before there was an issue about obviously getting the final changes through, particularly the one I've just discussed in the earlier meeting, into a workable format. I think it came quite late. I think it makes sense, but there needs to be workable from not just from our perspective, but from the DHSE's perspective. So I'll probably be able to provide an update to colleagues in the weekly update that we give to board, if that's okay.
Yeah, no, I think that would be good. I'm kind of expecting it now to be after the Easter recess, but
that's mine. And I think at the end of next month is probably the most likely time period.
Great, thank you very much indeed. Rachel, you're doubly welcome. Thank you very much for stepping into the breach. However, I think the board should know you've actually done all the work anyway on this, so as Jill would have been the first to admit if she'd been here. So can I just happily hand over to you, please? You need your microphone on, sorry, Rick.
Is that working? Great. I should just pass on that thanks to my team as well, who've done a huge amount of work into this. So obviously I'm here to talk about the 2021 WDES and RES reports. And as you know, these are kind of our key measures and drivers for our overall ambition to be a truly inclusive workplace, and to realise our ambition for a place where everyone can kind of fulfil their potential and flourish when they come to work. As you also know, this isn't our only source of insight, but does form a key part of how we monitor our diversity and inclusion strategy and, more broadly, our people plan. So I just wanted to draw out a couple of key elements, and then I'll kind of pause for kind of wider reflections. So I think I would note that there are some really great improvements that we've seen. So across the organisation, we are seeing increases of representation for Black and minority ethnic colleagues and for disabled colleagues. And I think I would highlight there that what that also does is support us in kind of some of our follow-on priorities in increasing representation at senior levels. So really thinking about the talent pool that we're building across the organisation and how we might kind of utilise that and grow that in the future. We are seeing improvements in appointments from shortlisting for disabled colleagues, which is fantastic. And we've also seen improvements in the number of, kind of a reduction in the number of Black and minority ethnic colleagues and disabled colleagues experiencing bullying and harassment. Although I would kind of just put a slight caution around that in that for disabled colleagues, that still does remain higher than for non-disabled colleagues, albeit actually still better than some of our NHS Trust comparators. So a kind of positive, but also more that we need to do in that space. And I'd also just highlight, so kind of not being too complacent, but so celebrating the positives, but focusing on some other bits. They've also seen an increase in discrimination for disabled colleagues, Black and minority ethnic colleagues. So we want to continue to focus on that over the next year. We've also seen some fantastic improvements in the number of disabled colleagues believing they have access to the right reasonable adjustments to enable them to do their work, as well as a reduction in people feeling that they are pressured to return to work before they are ready to do so. So some great improvements, but equally some areas that we want to continue to focus on. And I think you'll have seen from our paper that what we want to do for 2022 is prioritise some of the actions. So there's a kind of a huge amount of work that we are thinking about and we're considering, and this isn't to stop any of the focus on all of the metrics. But I think in our conversations with the WDES group, and with the Action for Race Equality group, we wanted to focus on 3 priority areas each so that we could really maximise our impact on the activity. So both groups have highlighted that they want to focus on improving the experience for people, believing that we offer equal opportunities for career progression and promotion. And I think I would just draw out there that the fact that there's a kind of commonality of ambition there is something we want to maximise and bring together the weight of those groups in sharing some of their experience and their thinking and their activity. And then there's some other areas that we want to focus on. So continuing to focus on the numbers being appointed from shortlisting for Black and minority ethnic colleagues. As I've already mentioned, increasing the representation at senior grades. And making sure that adjustments continue to be made for colleagues with an additional strand around accessibility to ensure that is our baseline expectation for everyone within CQC. So the final thing I would just note is that following our People Committee conversation, we're also thinking about how we have more regular check-ins on this data. So as well as having our kind of annual cycle of looking at the data from the last year, we have kind of quarterly reviews, so we're able to, in the moment, adapt and learn from what we're doing. And then, obviously, we will continue to track progress through our people plan overall. So I'll pause there. Thank you.
Thank you very much. Mark?
Could I just add a little bit to that, and thanks to Rachel. I think on the Workforce Disability Equality Standards, which I'm the exec sponsor for, I think this is our first year of running with this, and I think it's proven to be a really helpful framework for us to understand and measure ourselves against. And whilst we've seen some good improvements against the benchmark that we took, it provides us a real springboard for our action plan for the next year. So I think it's been a really valuable exercise. And one of the things that I've really enjoyed working on this is working with the Disability Equality Network. They are really at the heart of helping us understand and drive forward these improvements. So I think we've got a lot to thank for the Disability Equality Network as well.
That's really good. Thank you, Mark. Steve?
Thanks. Rachel, thank you. Brilliant report, actually two brilliant reports, and lots of good progress to celebrate. I was interested, firstly, in the issues about reporting, because within the disability report, am I getting this the right way round, there is a metric about did you report abuse and harassment, and that's sitting at 50.9% did. I'm not sure the same metric is in the BME ethnicity report, so I'm kind of interested in the organisation's approach to reporting and how far you think you've gained the confidence of colleagues that it's worth reporting, because 50.9%, and there's also a figure of 40.5, isn't as high as it might be. So sort of confidence in reporting, do people believe that if they bother to report it will be followed up? Do they feel safe in reporting? All of that stuff about reporting. Interested in your views. Thanks.
Okay, just on that point, so absolutely recognise the kind of lower scores around reporting, and actually that's one of the priority areas. So as well as focusing on reducing the amount of people experiencing bullying and harassment, the WDES project group have prioritised looking at how we encourage people to report that more frequently. So I think as a kind of overall point, absolutely recognise your kind of reflections there, and we're thinking about how we work with the networks to encourage people to kind of report and how we respond to that. I think in terms of the difference of metrics, that's kind of slightly outside of our control because that's a predetermined set of metrics. But I think one of the things we're trying to do is bring some of the insight between the two together so that we can learn from what the WDES is doing in this space and how that might apply with the REN network, for example. So maybe not necessarily within the parameters of the RES report, but more broadly how we respond to it in our diversity and inclusion work.
Great. Ian? Oh, sorry. Mark?
Thank you. Rachel, I think this is a great bit of work. I think there's a vast amount of useful information in here and a lot to be encouraged by, in that if we decide something's important, we focus on it, we measure it, we use recognised frameworks to tell us how we're doing, you can drive improvement and make it a better place, make this a better place to be. So I think that's enormously encouraging. I do think it provides another helpful triangulation point on bullying and harassment. We discussed at the last, or raised at the last meeting, disappointment with our scores on how satisfied people are that, particularly our internal experiences of that, have been resolved to their satisfaction. This gives us another insight into that, and I think, as we discussed last time, I hope we're going to try and do some things differently and experiment with different ways of reassuring people that we're listening and acting appropriately and responding to concerns that people raise. But I think it's a great piece of work, so thank you.
Thanks, Peter. Thank you. Thanks, Rachel. I echo the comments of other people in terms of the quality of the work. I think it's just worth just linking a few things together as well here. I think one of them is we are relatively blessed with a relatively low turnover as an organisation. So therefore, whilst we've done a lot of work in the background in terms of recruitment and expressions of interest and how people move around the organisation, the levels of movement in the organisation have been relatively modest in the last in the last couple of years. Having put that scaffolding in place, though, I then linked that to our transformation programme and the work we're doing on transformation. We are moving to a position where we're expecting there to be a fair amount of movement in the organisation. People that have been joining us on temporary contracts, we're going to be looking at making people permanent and advertising new jobs and so forth. So there'll be a degree of movement in the organisation. And I'm hoping that, if you like, the preparatory work we've done, which this report in part reflects, will mean that disabled colleagues and people from Black, Asian and minority ethnic backgrounds will be significantly better represented right the way through the organisation as we go through that recruitment process. So hopefully the preparatory work will pay dividends over the coming year, and what you'll see in a year's time is something which is quite different in shape in terms of the organisation than it is today. And one final point, I think, possibly sort of talking a little bit to Stephen's point, is we've done a lot of work, particularly over the last couple of years, on having conversations, open and honest, and sometimes quite difficult conversations around some of these issues around disability and ethnicity. But I do think the organisation, for me, one of the things which is quite difficult to write down as a number, but just a general willingness to have those difficult conversations that maybe we were less good at a couple of years ago. So again, I think that will pay dividends. It will enable and embolden people to call things out when they're not working. It will stop people from just thinking something is quite trivial and then sweeping it under the carpet. I'm hoping we can have those more open conversations, and we've created an environment for those open conversations to happen. And as Rachel quite rightly said, there's always room for improvement. But I think we, as a senior team, I think we're very committed to creating that space for the right conversations to take place. Thanks, Peter.
It's 12 o'clock, so can we just have 1 minute's silence and then we'll continue. All right, thank you very much indeed, and I think that's a poignant moment of reflection, so thank you. Right, back to the board meeting. Mark.
Thank you, Chairman. And Rachel, thanks very much. Excellent report and presentation. And as my colleagues have said, I echo all of their comments. So, you know, some good and which we should be really proud of, and some things that we need to work on. Very interested on the inclusive leadership pathway, and also glad to see some innovation around e-learning for anti-bias training. So, you know, we'll follow those with interest. I'm also feel that we've done a lot of work, or you've done a lot of work on adverse impact around shortlisting. And I think the more we cite that and cite the improvement in that will give us encouragement in terms of these reports. Just in terms of the reports, when we reported the last time, I said that really all those metrics in the DES and the RES, I mean, they're sort of straight out of Best People Management Handbook. You can't disagree with them. So in turn, they impact on our processes, on our leadership, on our management training, and our culture. And so the report, which is great to see, is full of actions and full of actions that are linked to our people plan. So I think your point about more regular reviews is very well taken, and I would like to see that also. But, you know, overall, please just continue this good work, and I look forward to seeing more improvement. So thank you.
Thanks, Mark. Oh, Robert.
I'd like to echo everyone's comments on how informative, great these reports are. Clear language, clear tables, and easy for even someone like me to understand. So thank you. And thank you for the direction of travel that all this is going in. I just had one comment and one question. One was that obviously these reports are about our approach to disabled people and people, black and minority ethnic colleagues, but the figures, frankly, don't look too great in some parts for white people either, or the staff as a whole, even though in most cases they are much better than the frankly shocking figures for the NHS as a whole. But I absolutely understand where we're going, and we don't feel complacency about this. The question I had was, and it's quite specific, but it was, I think it's page 75 of our bundle. I don't know what page it is of your RES report. But there's a reference there to an action to reduce stigma, and I just wonder whether that's what is meant by. We'll continue to highlight our black and minority ethnic colleagues' lived experiences to reduce the stigma, and I'm just wondering slightly what that means and whether you mean it. And if it's what I think it means, then we shouldn't be reducing it, we should be eliminating it. And I just wonder whether, I mean, it's just a comment, and I'm sure that it's meant in the best possible way, but if we are saying that there is stigma attached to colleagues from particular ethnic groups, that's quite shocking to me, and I don't think that's what we mean.
No, absolutely, and so I absolutely take that point, and we'll take it away just to make sure that we word that in the kind of truest sense. I think really it's about how we make sure that we are hearing people's lived experiences and the impact that it has on them in the workplace, and I guess how they then experience different processes and interactions. So I'll take that comment away to have a look at that
it's an experience of something that feels like stigma and isn't. I think that's
absolutely. Yeah. No, thank you.
Okay, so can we turn some microphones off? Sorry, Robert. Thank you very much indeed. Otherwise, the whole system breaks. Rachel, I think that's really good piece of work. Thank you very much indeed. And you've heard lots of complimentary comments from colleagues. So, can I just ask the board to agree the reports with possibly with some very minor editorial tweak on that last point that Sir Robert raised on stigma? Are we all agreed?
Agreed, thank you.
Perfect. Good. Thank you very much indeed. So, unless there is other business, Ian.
Yes, thanks, Peter. I couldn't let you finish the meeting without acknowledging that this is in fact your last meeting. and it's also Ted Baker's last meeting. And I think, we are, I think on behalf of all of us, I know Mark wants to say a couple of words as well, but I think we're sadly saying goodbye today to two members of the board who've made really vital contributions to patient safety and quality over frankly, a number of years. In Ted Baker, we've someone who's given 50 years of service to the NHS, who saved countless lives directly as a practicing clinician, as well as being as a medical director and in the last few years here at CQC. And as chair, Peter has guided CQC to the place that we are today, evolving how we work so that we can regulate well in this complex health and social care landscape that we've spent so much time today talking about. I think Peter and Ted, you think you've both exemplified integrity and real belief in the absolute importance of patient safety. And I think you'll both leave a substantial legacy, and I think it is an impact which will endure. So thank you for your work, both of you. Thank you for your contribution and also your friendship for all of us around this table. So before I finish, I'm just going to hand over to Mark, who I know wants to say a few words as well. Mark.
Thank you, Ian. Well, I'm good, and Ted has appeared on the screen, so I can talk to him directly. So after many years of service within the system and ultimately CQC, I wanted to thank Ted and Peter on behalf of and from the perspective of the non-executive directors. Ted, I'm so sorry you can't be here, and I hope you recover fully and speedily. Working with you for the past 4 years has been a pleasure. I want briefly to highlight 3 areas where you've made an impressive difference and helped us at CQC deliver our core purpose. Firstly, as a member of the executive team, you've consistently placed the patient experience at the heart of your reports, both verbal and written. At no time has this been more so than during the pandemic and now with the COVID recovery program. At the very heart of putting patient first has been your razor-like focus on learning and improvement, which is at the heart of our strategy. Secondly, you've always promoted collaboration with other ALBs and Royal Colleges in order to advance safety, and particularly a safety culture within the system. You've been relentless in the pursuit of this objective, and patients have benefited from your leadership in this area. And thirdly, you've always supported our own staff networks within the CQC, and as Chief Inspector of Hospitals, you've recognized the contributions that all staff groups within the hospital sector have made and continue to make to patient experience and safety. You've highlighted the importance of support, training, and development for healthcare workers within our well-led framework. So thank you so much, Ted, and we will miss you. Peter, you too will be greatly missed. Thank you for all you've done whilst chairing the CQC. Similarly, I will highlight 3 areas where your leadership has been instrumental in placing CQC at the level it is at today. Firstly, your focus on efficiency and effectiveness whilst not losing sight of our responsibility to the wider system and system users. You've led the way by building a strong executive team and kept us true to this task despite constant financial pressures. Secondly, your strategic leadership, enabling us in your time as chairman to go through a full strategic cycle and setting us up to focus our energies on successfully completing our second cycle, again with its emphasis on people and communities, smarter regulation, safety through learning, and accelerating improvement. And finally, your leadership throughout the last 2 years, which has skillfully blended the needs of the system with supporting the welfare of our employees whilst keeping a rigor around patient safety. Your leadership enabled us to be agile in our processes and responsive to all of our stakeholders when the country went into lockdown and providers were under so much pressure. And on a personal note, I think all of us who've reached out to you for advice have never ceased to be amazed at how accessible you have been, how the advice received has been valuable and consistently helpful. And we've all felt supported by you as we do our work. So thank you. And actually, I want to hand over to Robert, who's also going to say a couple of words.
This could be getting out of hand, but anyway. Robert.
Don't you worry, Mr. Chair. But having been on the board for quite some time, and in fact, throughout the time, both Ted and Peter have been in your current posts, I'm happy to offer a final 360-degree appraisal to send you both on your way. Ted, I'm going to talk in the third person because I'm going to watch you blush, I hope. Ted is a most remarkable person, and it's been a great privilege to have been able to work with him. His quiet and considered manner conceals a character which is absolutely committed to the welfare of patients and in particular their safety. He's consistently brought all his values and skills as a doctor, well, perhaps not the physical surgical skills, or at least I hope not, to the role of Chief Inspector. He's been fearless in speaking truth to power and in not giving an inch on demanding high standards for us all. One of my fondest memories of Ted was the day I was privileged to accompany him to a day at the BA Pilot Training Centre to participate in the course they run on patient safety. And he's smiling now. The boyish enthusiasm with which he took to playing with their very expensive toys was a joy to behold. However, I wouldn't necessarily trust him with actually flying the aircraft. But that was great fun. Peter, talking of 360-degree appraisals, I've just completed one for you, so you're leaving in the nick of time. I suppose one of the reasons I'm on this board is because I reported in some detail on one place's experience of board leadership, which was putting it politely, not that satisfactorily. So it's been highly instructive to see board leadership as provided by you, which is the polar opposite of that. From the moment you were appointed until today, you've been absolutely committed to CQ's role of protecting patients and the service and keeping both safe. You've brought to bear your experience of chairing an NHS trust, which has given you great credibility, I believe, and you worked assiduously as an ambassador of us to those we regulate, the government and the public. Many jokes are made about your former career, but none of them fit you. Under a jovial exterior, you really care about this organisation's work and about the people who do it, and you fiercely protected it when it's been necessary. But you also have that talent which is absolutely essential for leaders, and not all of them have it, I have to say, which is of listening to colleagues, in my case with commendable if undeserved patience, and that other essential talent you have, which is having listened to people, you take their views into account and you then move on to achieve consensus with apparently little effort, but if I may say so, real skill. So on behalf of everyone here, I'd like to wish you both every good luck and success in what you do next, and I'm sure you both will be doing things next, and I'm sure that from a little more distance you will be keeping a close eye on our behaviour and what we do in future. But thank you to both of you for everything you've done for us, but also, more importantly, for the patients and service users of this country. Thank you.
Ted, do you want to say anything?
Yes. Could I just say a few things? And first of all, thank you to colleagues for those kind words. They're very gratefully received. But I just want to say more generally, thank you to members of the board, both past and present, for their constant support and encouragement. These roles are high pressure roles, and you do need the support of colleagues on a daily basis to make sure that you're doing the right thing and focusing on the right areas. But I want to extend that to the whole CQC. They are marvellous colleagues I've been working with over the last 8 years at the CQC and the last 5 as Chief Inspector, particularly the team within the Hospitals Directorate. Their constant focus on the care and safety of patients never ceases to amaze me. I think they're a wonderful team, and I want to give them my biggest thanks. And just finally, I just wish the organisation well. The services we regulate in health and care are going through unprecedented times and facing enormous challenges. It would be nice if I was standing down at a time when the challenges, if you like, had melted away, but they haven't. The pandemic has brought them to the fore, and I don't think the CQC's role's ever been more important than it is today. So I wish you well, and you have my full support going forward. Thank you very much.
So I could say a lot, but I'm not going to, because this really could get completely out of hand. But I just want to say thank you to the three of you for those very kind comments. Ted, I want to wish you happiness and success in the next stage of your life and career. It's been great fun working with you. It's been great fun actually working with everybody. And, you know, as you said, Ted, this is all slightly high pressure at times, but what actually gets you through any pressure periods is the sort of friendship and support of colleagues. So thank you for that. And then the only final thing I would say is that in Ian Dilks, you have a superb new chair. And I guarantee within a few weeks you'll have forgotten that I was ever here, because you'll be very happy working with Ian, which is how it should be. So thank you all very much indeed. So that closes the formal board meeting. We have a couple of questions from Robin Pike. And Robin, you started your questions, because obviously you submit them in advance, by thanking me for allowing you to give the questions. Can I return the compliment and thank you for the questions over many board meetings? So the first question is it CQC's expectation that NHS and care home staff wear ID badges when on duty, as is the case for staff working in schools? And so, Ted, just as you thought you'd actually finished, I think you might want to start the answers to that one.
Well, can I thank Robin Pike again for the questions he's asked? He always is asking about pertinent points, and this is a very good example of that. There isn't a regulatory requirement that people wear ID badges, but there is a very clear expectation from us in our assessment of services that they should wear ID badges and they should introduce themselves. And I think we do observe care very carefully, and if staff are not introducing themselves, that's something we will comment on in our inspection, and it will affect our assessment of those services. I'm very pleased to say we were a very strong champion for the Hello, My Name Is initiative that came from the work of Kate Granger, which I think has been very influential in influencing the way staff behave at the front line across the services. And I should say that caring, the key question that would cover this, is one of the areas that scores most highly in our inspection reports. But having said that, there is always room for improvement, and we will be constantly vigilant in driving that going forward.
Thanks, Ted. Kate, do you want to add anything?
The only little thing I would add is I think it's really important we continue to focus on outcomes. So we look at, is the member of staff who's supporting the individual doing so in a person-centred way, and do they know their own care needs, etc. So you might, on a 50-bedded nursing home supporting people with dementia, expect all colleagues to have badges. If you think about 3 adults with a learning disability in a supported living setting, their own home, supported by a staff group who know them very well, you may not in that circumstance. So I think it's really important that our focus continues to be, can we see a well-established relationship with staff, providing person-centred support, and that it may not, we wouldn't necessarily want to say a blanket statement that says all health and social care workers should wear badges, because if I'm a care worker supporting a person with learning disabilities to go to the library or the cafe, I may not want it to be massively overt that I'm a member of staff.
Great, thank you. Rosie? No, that's it. I think that answers that question very fully. The second question from Robin is, when does CQC expect to allow members of the public to attend their public board meetings in person, as was the case pre-COVID? Well, actually, Ian and I did discuss whether it might be possible for this meeting to allow members of the public to come, but the really quite high level of number of cases of COVID really made us say that it was not sensible either from the point of view of just physically accommodating people in the room. You may or may not be able to see this, Robin, from the screen, but we are still sort of fairly socially distanced in this room. But secondly, also recognising that some of our colleagues around this table do then go and visit clinical settings and other places. So I think the answer to your question is that we will get back to that when COVID levels are really substantially lower than they are now, and assuming nothing else has hit us that makes it unsafe. So I can't give you a date, but that's the plan. So that is it, and as Ted and I finally finish, in the immortal words of the two Ronnies, it's goodbye from me and it's goodbye from him.